Ladies and gentlemen, it's time for us to start this special subcommittee meeting in the Regulated Industries Committee. If you will, take a seat. We have two bills today that are hearing only, House Bill 369 and House Bill 430, both presented by Chairman Allen Powell. Chairman Powell, when you're ready, we will take your presentation of these bills.
Committee last year, we were so successful of being so multi-talented that we actually got into some issues last year with the APRNs and the physician's assistants. And we cleaned up some issues last year, much to the benefit of the people of Georgia. The advantage about this committee that I have said for years, we're not the healthcare committee, so we look at things with a different set of eyes about how we can work on practicality and not being so unduly influenced by segments of the medical community. And last year I thought that came out pretty well. The two bills you're looking at today is one is House Bill 369 and the other bill is House Bill 430. Now there's been a lot of issues that's been pointed out to me that we're going to have to address on both of these issues. On House Bill 430, that bill calls for licensure, which means it would have to go through the GORP committee, which means that would be held over to next year. Now there's an issue or two in that bill other than the licensing that could be readily acceptable to this committee maybe, and that would be teamed up with an issue in House Bill 369. 369 basically, and we have some folks here that are going to speak on that that are far more knowledgeable than I am, but the physician's assistants and the advanced practical nurses. These folks have an enormous amount of skill, but they work under the protocol of the doctors. This is the framework that we put forth last year, and that's what we're putting forth this year. And in that one, this would allow those groups of professionals working under that specific doctor's protocol to be able to administer Schedule II drugs, which most of that would be in the case of weekends and emergencies in those situations when a physician wasn't available. Dr. Newton has got some ideas that he wanted to share with the committee, and some of them may be worthwhile or some may be questionable, but I have ample respect for the good doctor by all means. I think that it's what we want to do. Other states around this country, they allow APRNs and advanced practical nurses to do the same type of things. And, you know, what we want to do is be sure that the public has access to this type of medical attention. You know, if someone has run short of their medications and can't reach their doctor, then maybe they should be able to get to that PA or that APRN. That's the gist of these bills, Mr. Chairman and committee members. Now I'm going to ask for the latitude of the chair and the committee members. I regret it that I'm tied up on the Election Integrity Committee, and I've got to report back there in about 20 minutes or so to that committee. At least I suffer the penalty of pain and death in being accused of running off. But what I would like for this committee to do today is to hear the testimony and to formulate some ideas, hopefully based on what we had done last year, to see what's acceptable, what's not. If it's not, then those can be forwarded, like the licensing piece I referred to the GORP committee, and just see what it is. There's several of y'all that are on the committee that are far more knowledgeable than I am. My good friend Chairman Jaspers has served on the health committee for a while, and he has certainly, we may not always agree on things, but he certainly has a heck of a lot of knowledge on some of these issues. And that being said, I'd like to ask Sheila. She was a genesis on one of the bills, and Juliana, she's going to address the other bill. So first, if we would, on the Schedule 2 prescriptive, I'm going to let Sheila speak on that.
I'll try to be brief. That's not always my strength, but I'll do my best given the lateness of the day and the chairman's other committee hearings. My name is Sheila Humberstone. I'm with Stonebridge Consulting here today on behalf of the Georgia Association of Physician Assistants. There are about 5,000 physician assistants in Georgia licensed through the Composite Medical Board. This bill seeks to do two things, and when I say this bill, I'm referring to 369. Number one, regarding how physicians delegate their authority to physician assistants. Right now, that job description has to go back to the Composite Medical Board for approval before that PA can begin working. What we would like to see, which is done in many other states, is that we still require a robust job description, but that not necessarily have to be approved by the board. Both the physician has been licensed by the board and the PA has been licensed, and it seems a bit redundant to also then, when you start work, file another job description, or if your physician leaves and a new physician comes to work in the practice, to have a new job description that's filed at the Composite Medical Board. So that's the first thing that the bill purports to do, and we tried to do. The second is, I always like to look at what other states have done. So I looked at our contiguous states and looked at what South Carolina did. So we are the only state in this area that doesn't allow Schedule 2 prescription authority by PAs and nurse practitioners. And I looked at South Carolina was sort of the toughest of the contiguous states, and this bill models that language. So it's an emergency only, it's 5 days, there's some continuing education requirement on opioids, and I believe I can say with confidence that because of how the PDMP statute is structured, we would still be required to report to the prescription drug monitoring program. The state that doesn't allow any kind of prescribing is West Virginia, which has a opioid crisis in and of itself. So I don't think that we can say that by virtue of not having physician assistants and nurse practitioners not do it, that that's somehow protecting us. What I can tell you is that there are letters in your file from PAs and one from a physician, and I'm going to point out a sentence in the one from the physician. Together, we have provided effective and efficient care to thousands of patients, from newborn patients and patients into their 90s. As a supervising physician's ability to evaluate and establish appropriate parameters for a PA at the practice level is the most safe and effective manner to care for patients. The issue we have is oftentimes there's not a physician on site every day. And a PA who sees a patient who comes in with a broken bone or a kidney stone is sent to an emergency department from that practice solely because they cannot give them a script. They cannot write that prescription. So this seeks to change that. Again, a limited supply in emergency situations based on South Carolina's model. There's other information in your packet. I'm happy to answer any questions. I've got the DEA's list of what other states do if anybody's curious, but I don't want to bore you with all those kinds of facts. Certainly happy to answer any questions.
Any questions from any of the committee members of Ms. Humberston? Well, no, ma'am. Thank you very much. I'm sorry, Chairman. I think you're on now.
26, I think. Thank you, Mr. Chairman. Thank you, ma'am. I just had a couple of questions, just as I looked at this bill earlier. So where in this bill does it change the Composite Medical Board change? I was trying to find it. It's not in the first.
So it doesn't change the board. What you'll see is where, like,
Where at, excuse me, ma'am?
It's throughout the bill, so it's not in just one place. So if you start on line 81, line 80 and 81, you'll see it's straight approved for that physician assistant by the board. And the new language is entered into between the physician and the primary supervising physician.
Okay.
And you'll see that theme throughout the bill.
Gotcha.
Because of the structure of the existing statute. So if I flip through, you see the same thing on line 88, nurse protocols, and it allows them to continue.
Okay.
Let's see.
Yeah, I see
Line
it,
142.
132, yeah.
Yep, same thing. You'll see approved by the board, and again, entered into a job description. So we still have to have it. Certainly would be amenable to us filing, sort of like we do in insurance file and use, maybe filing the job description at the composite board, but I hate to think that we'd have to wait to start work until it comes back.
How long does it take for it to come back currently?
I'm not sure. I got some complaints from some of my PAs that particularly with COVID and there being next to no staff around, that it's a real challenge.
I'd love to know what, Mr. Chairman, what it would be prior to COVID, the turnaround on that.
Okay.
How reasonable or unreasonable it is. May I continue, sir?
Yes, sir.
Just for my education, I want you to look on, I'll make sure I understand this, on like 109 through 111. When we're telling here what they can do, and so this prescription drug order, I assume they will sign it with their signature, and then I guess I go through this initial must be in consultation with approved by delegating physician. How do they, approve it? Is it written? I mean, they were going to do another prescription, once they come back after the 5 days, I mean, they will write another order?
So I think it would depend on the practice. Certainly, there's some practices that use e-prescribing and that would have the technology to do things in a little bit more seamless manner. Many of my folks, they have to get actual signatures on those scripts, so they would have to come back for a script, at least is my understanding.
Sure. Just on line 105, it talks about, specifically included in the nurse protocol agreement.
Mm-hmm.
How detailed is something like that?
I've got a copy of it, so I'm happy to share it with you. I could not find online there wasn't much for I'm sorry, I'm going to move away from that, from the PAs, but I've got a copy of the nurse protocol agreement. From the PAs agreement, it looks like it's basically an attestation by the doctor, an attestation by the physician assistant, and then any other physicians that they're going to work under at that practice.
But does
So-
it spell out exactly what they can and can't do?
So there's supplementary ones depending on what kind of services that you want to provide. So, and that would be something that I would certainly entertain. Some states have said that if you allow for Schedule II, then you have to have an attestation back to the composite board saying, this is a big enough deal that we want you to we want to make sure that your physician has delegated that to you. And I can give you Alabama, I think, has done that.
Okay. And Mr. Chairman, I had to look up what attestation is.
It's a swearing.
Man, I mean, other members may know, but Mr. Chairman Powell may know, but I did not. And she's over there probably giggling. So, when we passed the bill a few years ago, I guess it was 2. It's very similar to this. We did a 3-day or versus 5 days. Any reason?
I just
3 or
looked
5?
at.
What's the?
Yeah, I wanted to look at what was going on today in the market in terms of the regulatory structure around us, and South Carolina had just increased theirs, and they were still the most restrictive around us. So I literally pulled the statute. I didn't. Betsy did, but we pulled it from South Carolina. So if
Okay.
it works someplace next door, usually I like to try to tap on to what somebody else is doing.
That's enough for me, Mr. Chairman. I'm sure.
Thank you, Chairman
Other
Jaspers.
members?
Any other committee members? Representative Everhart, do you have any questions of Ms. Humberston? Well, thank you, Ms. Humberston.
Thank
Chairman
you.
Powell, you have another witness that's coming now. Yes.
I do, Mr. Chairman, and I can assure you I will attest to the fact that I'm not the smartest guy in the world, but I tell you, I've got some of the smartest committee members, and we certainly have absolutely the smartest leg counsel who can put all of this ramblings together so that it works. I want to introduce Juliana McConnell, and she is the genesis of House Bill 430. I'm going to let her briefly go over that, and then hopefully, before I leave, Dr. Newton can say a word of grace over this at some point.
Okay. Okay, thank you. And again, I want to point out that both House Bill 369 and House Bill 430 does impact both APRNs and PAs. But as he said, then, Sheila and the PAs were the ones who, took the lead on 369, and then we, the APRNs, took the lead on preparing House Bill 430. And 430, basically, as the chairman mentioned earlier, the first part of 430 added an APRN license to the nursing board. Right now, when you are issued an RN license, just like a medical license, a dental license, all of the types of healthcare license. But then once you're an RN, and then you go on and meet the requirements to become an APRN, with all the stringent requirements there, from the master's degree to the time that they must actually have a test that they must pass, and so many hours that they must work, a whole list of what they must do to become an APRN. But when they complete that with the nursing board, now they get what's called an APRN authorization. So what this bill would do is it would add an APRN license. 38 other states in the United States do offer APRN license. For a number of reasons, that it's very important that they have a license rather than just a piece of paper that says an authorization, and even being able to track an APRN with a license number. Now, as the chairman mentioned, we just found out though that after we dropped the bill that this does need to go through the GORP process, and that we really would not have at this point have the adequate time to complete that process. So we will be working with them, because we certainly, we do not want to, with all the, I think they said 3 times that we'd have to meet. So we're going to be working with them. So this portion of the bill will have to be at least postponed till the next session, so that we can complete that process. Now, the second section of the bill, actually it directs to the sections 2, if you'll look on your list, 2.1, 2, 3, 4, and 5. Okay, this authorizes APRNs and PAs to order home health services. And the federal government just last year, in the CARES Act nationwide, did make that change. And they now authorize APRNs and PAs on a national basis to order home health services. But it does say it's contingent upon the state having laws in place that allow that. So all we're doing with this is making the change to the statute in Georgia that will then mirror and allow APRNs and PAs in the state of Georgia to also authorize those. We said if nationwide they feel that APRNs and PAs are qualified to do this, that we certainly hope that in Georgia that our APRNs would also be qualified. And we do have, 2 of our APRNs at doctorate levels that will be testifying, and they'll give you a little more information on why that's so important, especially now in this COVID environment. Okay, and then part 3 is that is just a change where we add APRNs and PAs to the list in the Georgia Department of Revenue Motor Vehicle Division as one of the healthcare providers that can authorize the issuing of disability parking permits. We really felt they made some changes from APRNs in the nursing language several years ago that we feel like that's probably covered, but we want to make sure that it's actually listed in their code section. And we did talk with the motor vehicle, it's the Department of Revenue Motor Vehicle Division. We did reach out to them, and they said they were fine. They had no problems with that. So it would add APRNs and PAs to that list. Okay, then the last section, a very important section, and it's only 2 lines, and it says that the Board of Nursing would be authorized to require the collection of workforce data from applicants when issuing and renewing their license. And that's only 2 lines, but it's extremely important. We have right now, with over 160,000 plus nurses throughout the state of Georgia, we do not have the workforce data that we need to be able to even know where nurses are and what they do on a statewide basis. And the Board of Nursing has tried to be able, they have a little survey that's when you go through the licensing process, there's a survey, but it's voluntary. So when a nurse is filling out their application for a new license or renewed license, it says you can, if you want to fill this out. So they have a very low, I think when they first started, it was like 14%. So it does no good when you have that kind of response. We need data from everyone statewide. So all this does, and it does not mandate the board do anything, but it gives the ability to the board to authorize the nursing applicants, where they can make it mandatory that when they're filling out, going through the process, that it says they must fill out that to be able to proceed to complete their license process. So that's all it does. It's not mandating right now. It's not anything that we're placing on the board. We're not telling them they have to do anything, but it would just authorize them to give them the ability to mandate that. Now, right now in the Georgia Code, it's actually the dentists. It is in Georgia Code that they have the ability to mandate that collection. And the Attorney General's office, the medical board has wanted to collect that data in the past, and it's already sitting there, like we said, but we just don't. We have very limited number of nursing applicants filling it out. But this would give them a teeth to mandate they have to fill it out. And it's just a few questions. And like I said, one of our, Dr. Eichenberger, who's here, she'll go over that a little bit more because she's been working on this for several years. The workforce, the healthcare workforce board that we already have in place, the data that's collected from the nursing board would go to them for them to be able then to use that data so it can help us statewide to know where our nursing workforce is. Okay, and that's basically what it does. And like I said, if we, and I know the chairman mentioned that that we can't proceed ahead with this year with the licensing, but the other three sections of the bill, I feel are so important, and it's not nothing compared to what we were wanting, of course, with the license, but they're all three very important. So I hope in some way, even, that we can at least continue to, and bring those three along either with this bill or however the chairman decides to go forward with that. Thank you. Any questions?
Yes, ma'am. Thank you. Committee members, are there any questions of the witness? Chairman? Yes, sir.
Thank you, Mr. Chairman. Yes, ma'am. I just have a question, just for my learning here, like on part one. In one, we talked about at the beginning of 31, and advanced practice registered nurse means, and we cross out a number of things like on line 34, who holds a master's degree, et cetera. And we add a certified nurse midwife, certified nurse practitioner, certified registered nurse anesthetist, et cetera. Do these all have similar training experience to what I read, like in lines 34 and line 35, that APRN currently has?
Well, of course, they're going on a different course of study, depending on which APRN degree they're seeking. But there are certain standards, just as they have to have a master's degree, they must have so many hours of training and experience. They must pass a certain statewide test. And I tell you what, we've got, like I said, the two ladies that are here, they're both doctorate levels, and they're both professors. One of them's a dean of the nursing school at Clayton State, and the other is a senior dean, but a professor at Georgia State. So either one of them can probably even give you a little more detail, even into the various types of degrees that they're working on. But they're comparable as far as the level, quality of education and hours and experience that they must have.
So you're saying, just for my knowledge and members, that a certified nurse midwife has a master's degree or a graduate degree from an approved nursing education program, board certification in their area?
Yeah.
They do?
Yes.
Okay. I just want to make sure. I don't know. I'm trying to find out.
Yeah. Okay.
Let's see. On section 2, we're talking about, I guess that's, if I've got it right, or may have my notes wrong, or I looked at earlier today. On the home health, I personally just went through this recently, and, you know, I guess what I saw in my local situation is the physician and all worked as a team in the care in home health. And how does this relate to that?
Well, can I wait and we have someone who is one of our, that's going to be testifying, one of the doctorate levels, can give you more detail on how the home health and how actually signing the orders to authorize the home health services, where it would just expand it from a physician to also to an APRN or a PA. But if you'll let them, when they're getting
Sure.
ready, when they testify, they'll have some of those answers for you.
Mr. Chairman, do you have any other questions of
No,
her
sir.
before we bring those?
No, go
others
ahead,
up?
sir. Thank you.
Yeah, okay. Chairman Powell, do you need to go to the elections committee, or something else? Did you
Yes, sir, I
wanna-
do. I would like to just say a little bit before we meet again, probably tomorrow. The mode of my operation would be, after y'all scrutinize these issues, that we will probably move forward with 369, take the acceptable language and issues out of 430, leave the licensing and whatever else in the other bill, so we can move that on to GORP for it to be looked at during the interim. I would be especially grateful for y'all to take a good look at how this needs to be crafted to make it a workable piece of legislation. As we had said earlier, surrounding states, I mean, this isn't inventing the wheel. They do these things, and it's good for the patient communities in those states. I know that the ARP folks have called, that they're highly supportive of this. And in my absence at this other meeting, I'm sure that y'all are going to have an opportunity to hear that. Now, we have another member that's probably way more important than I am. I wish he was going to the elections committee instead of me. But Dr. Newton, you know, he's got, and I'd like for y'all, if you would, at the prerogative of the chair, if you would let him give his information and then move to the other folks. And I will be speaking to y'all shortly if I come out unscathed.
Thank you, Mr. Chairman. Chair recognizes Dr. Newt for his testimony. Thank you, Doctor.
Thank you, Committee Manager Chairman Powell. Thank you for asking me to kind of give some background for the committee on just another view. I know Ms. Humberstone had a letter, I think, in your packets of a doctor who's seen thousands of patients. I too, since over 20 years ago in the Army when I showed up, and the PAs, you knew where everything was, the physician assistants that I worked with, but we made a good team together. I did that in the Army Medical Corps. I've done it for over 20 years since then with numerous nurse practitioners, and I can tell you the state of Georgia is blessed by having some incredible nurse practitioners and PAs, APRNs, CRNAs, everyone who do an incredible job, and I look forward to seeing us all work together. There are some differences and a couple of similarities. The similarities, I'll tell you, from the begin with, is a commitment to patients. That's similar. That's very strong and a strong ethics-based attempt to approach that in a scientifically sound way. So we're strong in that commitment. Another thing we're doing actually is we're all practicing medicine. This, when you've gone and gotten a master's degree or a doctorate level, whom we'll hear from later, you're actually practicing medicine now. That nursing is a protocol, and frankly, the Board of Nurses, I believe, is either 95% or more nurses. I'm sure they're doctorate level nurses and different things, but not necessarily APRNs. I would say that both physician assistants, physicians, and APRNs are practicing a form of medicine in Georgia. So we all need some oversight. I do. I know we just finished an HHS committee meeting to where we expanded the powers of the medical board to oversee doctors who step out of line in an area. That's because we understand that even after years of medical school and residency and board certification and maybe experience, we all need someone or a group in this case to oversee us. And I think the best group as a background to oversee the practice of medicine, whether it's done by an APRN, a physician assistant, or a physician, is the Georgia Medical Board. I think that's a consistent thing, and I think it makes a good sense. We did see in a study committee a couple of years ago where we went and visited the nurse practitioner schools and some of the PA schools and some of the medical schools. We got some raw data or background data on the number of supervised clinical hours that there were in some of these programs, and it was around 700 to 1,100 for some of the nurse practitioner programs, maybe 1,200 to 1,600 for some of the longer physician assistant programs. But when you have a woman coming out of med school, over 50% are female. So when you have a young woman coming out of medical school, they've had about 5,000 hours of supervised clinical training just getting after their senior year of medical school. And I mean a test every 6 weeks in this training, a broad-based approach to medical care where you learn more and more about the challenges that there are in diagnosis and treatment plans. Then, of course, almost everybody, pretty much 100% now of those women and men, go on to a residency program from 3 to 5+ years. So that's about 3,000 hours a year. So you got another 9,000 hours of supervised clinical training with gradually increased responsibility each year. They used to say the most dangerous place in a teaching hospital, is July 1st, because that's when all the new interns who were a med student 2 weeks ago now are wearing a white coat with a stethoscope, and you can't tell them from, unless you're careful, you don't know who's who, because you still, after 4 years of med school, 5,000 hours of supervised clinical training, you still need that next 9,000 to really do your best for patients in Georgia. So, and that's for like a family medicine or internal medicine program. So this is a team approach. You end up with 14,000 plus hours of supervised clinical training, quarterly exams comparing you to your other residents, annual in-service exams comparing you across the country. Some people I know in my residency got an opportunity to get it right a second time. I think we heard a quote recently. They got a second opportunity to get their second year right. And then finally you have a board certification exam and then board recertification exams. The bar we set for these women and men in medical care is a high one because we have high expectations, but we can't do it alone. So we form a team, and I think Chairman Powell and Chairman Nix were very persuasive last year in the fact that practicing medicine is a team sport, and everybody doesn't have to be trained exactly the same, but it needs to be done as a team. So that's what I see as the value. And one of the bills, 430, talks about skilled nursing facilities or home health. Some of our elderly are some of the most challenging patients when it comes to balancing multiple needs. I'm not saying that one APRN or a physician assistant can't do it. Sometimes, even as physicians, we need a geriatric specialist to help us, maybe an oncologist to help us. It is a team sport, and this team actually works best if there's a physician leading it. This woman or man with over 15,000 hours of supervised clinical training, not just on-the-job training, but supervised clinical training, working with a team of nurse practitioners and PAs to take care of somebody on 12 or 13 medications. It's just best if you can start that together, and then obviously it's incredibly valuable for someone to do the monthly visits going forward, maybe for a year. As long as everything's going well, certainly we understand with diabetes, congestive heart failure, COPD, a bunch of different things. But skilled nursing facilities, some of the language in the second part of, I think, House Bill 430, after the licensing that may get pulled out, some of those things are very complex decision-making processes that I believe we benefit from having a team approach, and from that team having someone who is actually, because it's practicing medicine, that's someone who's actually completed and overseen by the Board of Medicine. Once again, I go back to the fact the board oversees me as well, because plenty of doctors step out of line in numerous different areas, whether in medical care or other decisions, and we need to be responsible to a different authority. I got to say, there's a lot of APRN capabilities right now for nurses. We have a little bit of a nursing shortage in Georgia right now, and there's a piece of that because a lot of nurse practitioners around the country are getting a nurse practitioner degree. You're going to hear from in a minute, I'm sure, the cream of the crop. That's who shows up here when we have a doctorate level, a doctor of nursing practice, I assume, it's going to speak to you. what we've seen in my years of working, and I work today with 8 PAs and nurse practitioners. My group works with dozens in both an emergency department setting and an urgent care multiple office setting. We know the incredible value, but we also work elbow to elbow as part of a team, and we know when to discuss challenging patients. I can tell you on the 369, there's some language on your substitute, I believe, that you're working under that I actually really like. I like the idea of the 3 days. I'm fine with that. PAs and nurse practitioners used to be able to prescribe Schedule III medications without a physician countersigning it. Then the feds moved hydrocodone up. So a couple of years ago, we talked about a plan to allow a limited, maybe a 3-day supply of that very idea that someone can be out in an emergency department or in an office setting. You've got an acute pain problem, a broken bone, a kidney stone, as was mentioned. I think as the language says, the 3-day supply, I personally, as a physician, don't have a problem with. I think it could be advantageous. I know a few years ago it was vetoed by the governor, so I would like to put a little safeguard if it was up to me, and that I think is in line 109 through 111. For example, I know there's one section for APRNs and there's another section for PAs, but this is talking about approval documented in the patient's chart, that it's approved by the physician. We all are trying to figure out, a lot of us physicians, as I mentioned earlier, the board's had to reprimand for inappropriate pain medicine prescribing. And me, with 4 or 6 people working alongside me to take care of patients, I could be delegating something wrong. So I think one reason my delegation, my job description, as was mentioned, I think for the PAs, or sponsoring agreement with a nurse practitioner, I think those do need to be approved by the board, because they need to hold me accountable if the practice of this team is going outside the bounds of what they think is safe for Georgians. So, but I think that the idea of giving the approval, or at least I'd had a substitute to this that just gave them up to 72 hours to notify their physician, with the key point being the physician's going to know when these sickest of the patients are getting treatment. I hope everybody's not getting a hydrocodone or Schedule II prescription. That should be a small subset. It's a small subset of my patients now, even in emergency department practice. But that should be a small subset of the patients. And I think it's reasonable to say, either notify the physician that you're prescribing this, or notify them within 72 hours. That way, if a physician who's working in teamwork with a nurse practitioner or a PA, they'll have access. So when the board calls that physician, it won't be that they could say they didn't know or they didn't review that particular chart. It would be to recognize that opiate prescribing is something really for the sickest 5 or 10%, maybe less, of your patients. I really would have argued the same thing last year, not argued, but I would have added that same idea with an MRI scan. I don't even, once again, I work in a trauma center and take care of people ejected from a pickup truck. We don't order that many MRIs. The MRIs are definitely my sickest patients, and I thought that would have been a good addition to last year's bill that would have really garnered much more of my support at the time, because I think that would have established that for this subset of the sickest end of your patient spectrum in a day, and I would include those requiring an opiate for pain management, that's a good group to at least notify your supervising physician that you're in a teamwork with, or at least notify within 72 hours, recognizing this weekend problem of some of our ER staffed by PAs and nurse practitioners on a weekend. And that way there could be this team approach. There'd be some oversight, just like I have oversight from a board. I think it could be an excellent thing. We're seeing, like I mentioned, a range of nurse practitioners of varied levels of training. And I wish I could tell you that the people who'll talk to you today are average, but they're not. They're not going to be average. They're going to be people I would love to see if I had a medical problem, and you would too. There's a vast range. We need to keep the safety net, if you will, of that different level of training, the different level of experience. And once again, when I say training, I don't mean on the job. I mean supervised clinical training with testing and all that goes through that 14 or 15,000 hours I told you she has at the end of her training. I think if we do that, we can be doing what's best for Georgia. We can work on getting away that these maybe 3, maybe 5 days. I'd probably support the 3 days of a Schedule 2. But anyway, with that, I mean, that's just those are just some thoughts I'd had for Chairman Powell. He asked me if I wouldn't mind sharing them with the committee, and I'm glad to answer any questions or clarifications.
Well, thank you, Doctor. Committee members, do we have any questions of Dr. Newton? Chairman Jaspers.
Touch me there. Thank you, Mr. Chairman, and seatmate. And I know we talked about this a little bit today. So, Chairman Newton, we asked about the board. Came up in the questions I asked just a moment ago. Is it burdensome? I mean, I guess the time that you may send a report in that you get some response back, whatever the response is, I don't know, but in your opinion, is it burdensome?
It is, well, two sides to that. I don't believe it's a burdensome process right now, and if expedited by a bureaucracy, which some of this is, especially if it's the same job description we've sent in for an earlier, say, physician assistant or a protocol agreement with another APRN, you'd think it would be fairly expedited. I would like to see both of them go to maybe they do both go to the medical board. Mm-hmm. I would almost favor something that said if they say it usually takes 7 to 10 days, then let's just say 10 working days, and if they haven't responded by then, it's automatically approved. There may be another solution other than just cutting the board out of getting it at all. To me, I think the board, because once they have that in writing, they also have something. If I or anybody on the team I work with is violating it, and they have it in writing, well, then they have a cause of action against my medical license, or maybe the licensing for both APRNs and PAs. Maybe those need to be at risk too. But obviously, there is a team leader in that, and so that's where the medical board has a strong authority over a physician and anything that's been delegated by that physician of the practice of medicine.
Sir, okay, thank you. Mr. Chairman, I'll keep going if you don't mind. Chair, I can't remember from a couple of years ago, we were talking about the 3-day prescribing of an opioid, or 5-day or 10-day. I mean, what's the, I mean, in your training, in the research that's out there, what's the big difference, takeaway? Or is it just a personal preference that it'd be 3 days or 5 days? Is there like research that says one's better than the other or not?
Well, there's two different things we've talked about in the last few years. One was in when you had to check the PDMP, the prescription database for narcotics. So there was some threshold below which it was thought this is so unlikely to be an addiction problem. And I think that was the 3 days. That was one time we talked about it.
Yes,
but there was another bill that came up, and I believe we passed it, and it was vetoed, I believe, by the previous administration, that I believe authorized, it was in response to hydrocodone moving from Schedule 3 as at a federal level to Schedule 2, and therefore being unable to be prescribed. 3 days and 5 days, I don't see a tremendous difference. Really, for acute injuries, you should probably be, if you've had every 6 hours for 3 days, if you still need an opiate, I would say you probably need a follow-up. If you've, okay. In particular, once again, as I mentioned, the level of training and experience of an APRN or a PA varies dramatically. There's not this opportunity that I know of, well, there's a handful of them, to go do a residency of 3,000 or 6,000 or 9,000 hours. So it depends on who you're learning from, if you're learning kind of on the job or through experience. So there's just such a variety, and I'd probably lean toward the 3 days. I think nobody really takes it every 4 to 6 hours if you prescribe it that way. I think in the substitute I had proposed was fairly generous in the 3 days, and people space out. You know, they don't wake up in the middle of the night and take a 6-hour dose necessarily if they're sleeping well. I thought that got the acute need that was out there to take care of patients and not require them to go to a different location or something. I thought that would solve the problem, but also solve what was a very real governor's administration concern was, you know, this could get out of hand. You got how many more? You got thousands more people prescribing opiates is the question. I thought that by requiring this immediate notification, or at least within 72 hours, so there could be sufficient oversight and control if necessary by both the board over the physician or the physician along with the teammate, I thought that would be a compromise to try to prevent a problem with tens of thousands of new prescribers of opiates. I'd probably shoot for the 3 days and include something about prompt notification, or at least, and I will tell you, notification is much easier than it was in the past. For somebody working down in Rennes, Georgia, or in Louisville, we're on the same electronic record system, so it's pretty easy to send me a message. In 8 different offices I oversee, it's pretty easy to send a supervising physician a message on that program, far more so than it was even 10 years ago.
Oh, sure.
So I think the notification piece has both gotten a lot easier, and the opioid attention has gotten a lot greater, and that would be a good safety measure.
Mr. Chairman, following up on that very issue, I mean, you right now, with your protocol that you would develop with an APRN or a nurse practitioner, whichever, you as a physician could say right now, if you do this, you've got to notify me within 72 hours. Could you not do that? As you described a minute ago?
Sure. I guess, once again, though, as I mentioned with the medical board, and a big part of their job is policing us and physicians who aren't making good decisions. And as I mentioned, just the differences in training from a doctorate level nurse practitioner to someone who, set up their own rotations without, trying to get their clinical hours, shadowing hours even. There's such a big difference. I think having the board be in that loop.
I guess maybe I misstated it, Mr. Chair, but I guess what I'm asking is, when a minute ago we were talking about that you would like to be in the rule here, that if an APR, someone did write a prescription for that, you should be notified within 72 hours.
Yes.
Well, I guess I'm asking right now, could you not, in the agreements you make with me, if I work with you?
Sure. But the people who would make that level of supervision, you have lots of doctors with Georgia licenses who've never set foot in Georgia.
Yeah.
So you got to remember, with telemedicine and some other things like that, just because you're a licensed Georgia doctor, and believe me, those doctors care about their license in Georgia because it would affect the other 28 they may have, or 48 they have to practice telemedicine. You've got a range of us, and by the same time, so the physician group that would want to put that in their protocol on their own is probably not the group you need to worry about. The group you need to worry about is the one who would just lackadaisically just photocopy something, maybe never even meet the nurse practitioner or PA that they're supervising. And so I think we need to tighten up that teamwork and make it a true team, as Chairman Nix and Chairman Powell alluded to, eloquently, I might add, a couple of years ago. I think this is a great opportunity to both expand the capabilities of these valuable providers, but at the same time keep safety for Georgia and keep citizens and keep I think just keep it as good of a team as possible.
Sure. Thank you, Mr. Chairman.
Thank you, Chairman Jasper. Any Representative Earhart, do you have any question? Well, thank you, Dr. Newton, very much.
Thank you for the opportunity.
your testimony. Thank you.
Good luck.
Next, we had a couple of folks who were going to testify as a follow-up, 2 physician assistants. Is that right? 2 here today. Those 2. Okay, ladies, if you will, come up and give us your testimony, please.
Good afternoon. I'm Dr. Lisa Eichelberger. I'm the Dean of the College of Health at Clayton State University, and I'm the chair of the Georgia's Nursing Workforce Center Data Advisory Committee, which we advise the Georgia Board of Nursing and the Georgia Board of Healthcare Workforce on their data, the data that they collect. So I want to thank you for the opportunity this afternoon to come and speak to House Bill 430, the nurse licensing bill. And it will most certainly, I believe, advance nursing and healthcare delivery in our great state. As Juliana McConnell told you earlier, House Bill 430 has 4 parts, and I'm going to address 2 of them, although the first part may not stay in the bill. That's creating a separate license for APRNs, and the second part I'm going to talk about is requiring the completion of a survey when nurses get or renew their license to practice nursing in Georgia. As the Nursing Advisory Center Advisory Committee Chair, I, along with 4 other PhD-prepared nurses, work hand in hand with the Georgia Board of Nursing and the Georgia Board of Healthcare Workforce to provide data. And we try to predict the trends about Georgia nurses, who are the largest group of health professionals in the state. But unfortunately, due to the way current Georgia law is written, that is darn near impossible. For 10 years, I personally have worked with the Georgia Secretary of State's office to try and solve the lack of meaningful workforce data. And I am sorry to say that that still has not happened. APRNs currently are granted an authorization to practice, as Ms. McConnell told you earlier, to practice rather than given a separate RN license, a separate APRN license like recommended practice in 38 other states. And in Georgia, APRNs only have a basic RN license number, making it significantly more difficult for us to understand their employment practices and educational progression. So we're asking that rather than granting an authorization, the Board of Nursing grant them a separate license to practice in keeping with national recommendations. We've discussed this with the president of the Georgia Board of Nursing, board members, and Gabriel Sterling, and they have no opposition to a second APRN license for APRNs. Now, the second part I want to address are 19 words in Part 4-1 of House Bill 430. House Bill 430 is not mandating that we require a survey upon relicensure, but is rather granting the authority to require the collection of workforce data when nurses obtain or renew their license. Right now, the way the law is worded, it is an optional activity that nurses fill out this survey. And what happens is that they can opt out, they can fill out some of it, and as Juliana told you, the return rate can be around 14% or even less. So it's very difficult. I can't tell you, no one can tell you where Georgia's nurses work or how many left Georgia to go to Texas or New York during COVID crisis. We don't know whether they work in rural Georgia or whether they work in metro Atlanta, or how severe the nursing shortage is, or how it's going to be the next time we have a crisis or a natural disaster. So currently, Georgia law empowers the Board of Dentistry to collect workforce data on dentists and dental hygienists. However, twice now, the Attorney General's office has ruled that because the way Georgia law is written, we can't ask the existing 20 questions. There's 20 questions that we want to be able to ask and require on the survey. This past summer, the Georgia Center Workforce Advisory Committee met with members of the Board of Nursing and the Georgia Board of Healthcare Workforce and discussed the process of us requiring the survey, and the board members were in complete support of the survey being required during licensure. So we're asking that if you would support House Bill 430, we would really appreciate it, and it would untie the hands of the existing agencies that are supporting this vital piece of work. Thank you very much for your time and attention. I'd be happy to answer any questions about these 2 issues.
Thank you, Doctor, for your testimony. Questions from our subcommittee? Chairman Jaspers, do you have any?
Thank you.
Representative
Number four-
Earhart.
I'm number 14. So just so I'm clear on this, I like to just kind of repeat it back to make sure I'm understanding. This, you said the survey is 20 questions.
Right.
And it would be required.
Correct.
Give me an example of what type of information might be on this questionnaire. I'm wondering what is most valuable to you, and are the nurses themselves the only source of this information, or could the same sort of information be found perhaps if you're looking for how many nurses are in Georgia, how many have moved out? Could you garner that same information from their employers, the hospitals, the doctors?
Right. I have a copy of the survey if you would like it. I'd be glad to provide it for you. Yes, this is the only source. And we belong to a national forum of workforce centers. And this is a national, we are using a standardized national workforce survey. And it asks for their gender, ethnicity, race, year of birth, highest educational level, and where they work. There is no other source for this. Believe me, we've tried to garner it. We have asked hospitals to provide this. They are very proprietary about this information. And so that has not been a source for us. So we've not been able to get it in any other way. The medical board and the PAs, they are able to get it because they don't have an optional tab on their survey. And it's not required by law, but they don't tell the physicians and the PAs that it's optional, so they think they have to do it. And then if they don't fill it out, because their numbers are so small, there's only 11,000 physicians and even smaller numbers of PAs, they have the resources at the healthcare board to actually call them and fill out it. So they get a complete survey because they have the numbers to do it. With 160,000 nurses, there's just no way. We don't have the manpower to do that. So there's really no other way for us to get it other than to put it in the law and require it. So that's why. But it's really the zip codes, making them tell us where they work, put the zip code. So it's not that we would know exactly where they are. And of course, it's all de-identified. There's not any way that we would know,
Wait, I'm sorry, repeat that part. It is not.
It's de-identified.
De-identified.
Yes. So
Okay.
We don't know and wouldn't be able to track to a person. So just the analyst has that information. So their privacy
So you're
is
not
protected.
infringing on any particular individual's privacy?
No.
Because I know sometimes folks are hesitant to answer.
Correct. And of course, it's a massive data set, 160,000, and but only the only analyst has that.
Thank you.
That
Thank you.
information. But I'd be happy to share a copy if you want to actually see it. Thank you.
Chairman Jaspers.
Thank you, ma'am. Thank you, ma'am. I do have a question.
Doctor, I'm sorry, Chairman Jaspers did have a question.
So just following up, just for, so what if they don't fill that out?
Well, what if they don't? They would not be able to get the license.
Okay.
That's the way it is done in dentistry and dental hygiene.
Okay.
They're not able to exit, so they can't pay and exit.
So, and following up on that, so if I'm just curious at the information you're acquiring. I mean, if you're getting down to, let's say, X hospital paying a person in a certain classification a certain amount of money, is that in those questions? I'd be curious.
Let's see, their salary is on here. I don't believe salary is on here. It has their address, hours worked, and position. Salary is not asked for.
So it does ask for as following Ms. Earhart's question, it does identify who they are by their address. Is that not
Yes.
true?
Yes, the Board of Nursing absolutely has their name and their mailing address, and yes, it
Certainly, but
definitely
we're
has
talking
that.
about the survey portion now.
Yes,
So does it include identifiable information on the survey? It sounds like
Yes.
it does.
it does. It does.
Thank you.
You're welcome.
Thank you,
Any other
Doctor,
questions?
for your testimony.
You're welcome. Thank you.
Yes, ma'am, if you will come up.
Good afternoon to the committee. I'd like to say first and foremost, thank you to Chairman Powell for allowing me to be here to talk about these bills and the rest of the committee. And I'm going to be speaking about both, House Bill 369 and 430. So I'd like to start first with 369, that is specific to Schedule 2s. My name is Dr. Michelle Nelson. I am the state president of United Advanced Practice Registered Nurses of Georgia and the co-director of the Coalition of Advanced Practice Registered Nurses of Georgia. I am delighted to speak with you today about House Bill 369, and as was stated before, I'm also a professor at Georgia State University. In October 2014, the FDA moved hydrocodone combination drugs from Schedule 3 to Schedule 2. This was not based on congressional action, but solely the act of federal legislators, thereby changing what Georgia law has been permitted for APRNs and PAs to order. There are a lot of individuals in the state, advanced practice nurses, along with PAs, who are missing an opportunity to be able to meet the needs of Georgia's constituents, patients, and clients. Particularly in mental health care, there's a lack of providers for mental health care. Psych mental health nurse practitioners and clinical nurse specialists are educated to provide care to persons with mental illness. They're the only mental health providers other than physicians and PAs who can safely prescribe and manage the drugs needed to treat these patients on an outpatient basis. In many cases, prescribing a medication, including Schedule 2, is dictated to be best practices. There is a lack of providers also with palliative care. Palliative care is specialized medical and nursing care for people with serious illnesses, regardless of their prognosis, and it is focused on providing patients with relief from the symptoms, pain, and stress caused by illness. The goal is to improve quality of life for both the patient and the family. Advanced practice nurses can fill the gap if given Schedule 2 prescribing privileges. Advanced practice nurses who work in urgent care, who treat injuries, cannot write a prescription that will allow a patient pain management until follow-up with a physician or an orthopedist for further evaluation. This increases cost, requiring an MD to be present in the urgent care setting at all times. I want to share with you some patient accounts that have been sent to us that demonstrate how this is problematic. Our very own, I want to start with this one because it was discussed in the PA and APRN study committee that was held the year before last. Our very own Senator Gloria Butler gave an account of falling in the fall of 2019. She injured her wrist and was able to receive an emergency prescription on a Friday evening. She shared how she would never have been able to bear such pain for a sustained amount of time without a short course of the appropriate Schedule 2 medication to relieve her pain and suffering. Another one of our colleagues reported to the emergency room with her husband in crisis due to kidney stone on a Friday evening. The delay in care and unnecessary intense levels of pain caused him to have a significantly negative healthcare experience. He had to report to an ER and spend the night to receive care and had intense pain in the process. This delayed care and increased cost due to an unnecessary ER visit. These are some provider accounts now from the Vice President of United Advanced Practice Registered Nurses. Her name is Ashley Blackman. I've worked weekends in family practice, urgent care, and acute care. In family, my doc would not be on site, so I could never prescribe narcotics. I sewed up a guy's hand since I could, and he didn't want to go to the emergency department, so there were no narcotics given to him. On the weekends, docs don't stay all day at the hospital. So if there's a late discharge with someone who had a procedure, well, no medications available for them. Most of us know how to ask ahead of time, but it is a constant to do, and sometimes it gets missed. Patients need more than 9 to 5 weekday care. Another testimonial from a provider. I work subacute rehab. Often patients come from the hospital with no prescription for Schedule II meds, and the MD won't see the patient for 2 to 3 days. Patients have to wait for their chronic or acute pain meds. Tramadol does not fix everything. Most recently, a patient came in with chronic pain on OxyContin. I did get that doctor to write a script. However, they wrote the wrong one, and the pharmacy would not fill it. This chronic pain patient was without her long-acting medication for more than 3 days. It's dangerous and it's not okay. Testimonies and accounts from innumerable patient and client stories, as well as APRN providers such as these, underlie the need for APRNs and PAs to gain the authority to prescribe Schedule II narcotics. This will better serve patients and potentially lower healthcare costs for consumers. Additionally, we'll be empowered to address and increase patient satisfaction, patient trust in the medical establishment, provide timely and adequate evidence-based patient care, and decrease patient cost, burden, and delays in care. I'd also like to be able to speak with you about the 430 bill. And I want to start with talking about home health care. So the ability to order home health care has been granted at the federal level as part of the CARES Act, Section 3708, in March of 2020. While these sections remove the federal barriers for Medicare and Medicaid patients, consistent with longstanding language in the Social Security Act, an NP or a PA still must be practicing in accordance with state law to practice these services. We are seeking to have our state laws amended to allow for APRNs and PAs to certify the need for home health care. Many patients cannot leave home without great difficulty and need intermittent nursing, physical therapy, and other skilled care that only a trained professional can provide or supervise. APRNs and PAs are well poised to meet a growing demand, which would allow patients or clients to remain in their homes. Many nurse practitioners currently visit patients' homes where they can diagnose and treat chronic illnesses as well as acute illnesses, administer immunizations and IV drugs, prescribe and manage medications, and order, interpret lab tests and x-rays, among other things. And in many of those cases, APRNs who see these patients and are intimately involved with them, with their care, they personally know them, they should be the ones to allow or to be able to prescribe whether home health care is needed. In many instances, physicians rely upon the say-so of the advanced practice nurse, having never seen the patient themselves. HB 430 will provide access to home health services and promote continuity of care for Medicare beneficiaries, particularly patients living in rural and medically underserved communities, where NPs and PAs may be the only providers available, as we know that there are many counties in the state of Georgia where there is no physician. The president of AANP, Sophia Thomas, states it is imperative to recognize the critical healthcare needs of seniors and the importance of authorizing NPs to certify and recertify home healthcare services to Medicare patients, especially during the pandemic, when we do not want our elderly, our underserved, our underprivileged and vulnerable, as Chairman Newton said, the most fragile among us. We don't want them to have to leave home, or if you have an acute illness, to be put into a nursing home. This law will help ensure that seniors have timely access to home health care and reduce their potential exposure to COVID-19. This is not just for seniors, but for others that have severely debilitating diseases requiring them to be housebound. Authorization of NPs and PAs to order home care services for patients will ease some of this burden of hospital systems facing the influx of patients with COVID-19. As we know, here in Georgia, we've had multiple hospital closings and multiple hospitals that have been stretched to the max when it comes to admissions into hospitals. Additionally, access to care issues will be addressed as a greater number of highly trained, certified, experienced, and licensed providers are authorized to provide greater access to safe and quality care, particularly for our most vulnerable. This can prevent unnecessary placements in nursing homes and allow them to remain with family in familiar surroundings. I also wanted to speak with you very quickly about parking placards, which is one of the points of consideration in Bill 430. Georgia residents have significant chronic illness and disability, but they go places, they drive and mobile only when a caregiver is pushing their wheelchair. However, we are one of only two states, one of only two left in the nation that have these barriers to APRN's disability certification. And as a remedy, 430 would authorize APRNs to sign the affidavits providing proof of disability for disabled parking placards. The change would also allow APRNs to the list of, it would add them to the list of healthcare providers who can currently sign affidavits to authorize these placards in that code section. Changes have already been made to the code, 433425, and experts contend that code change included authorization to allow APRNs to sign these affidavits, so we can already do this. However, the proposed change that we request would specifically add our name to the list as APRNs in that code section that provides a list of providers authorized to sign the affidavit for issuing a parking permit. So what this does is it merely eliminates any conflicts on interpretation of the statute. This bill would also allow PAs to the authorized list. Passage of this bill will provide for better mobility to meet self-care needs among Georgians and reduce caregiver burden. Before I take my seat, I do want to have a moment to address some of the comments that Chairman Newton made. And although I represent some of the most elite APRNs and nurses in this state, I was an average bedside registered nurse before I became an APRN. I was a registered nurse nearly 9 years working in an ICU. And a lot of the doctors that came in June and July, I was one of the nurses at the bedside that made sure that patients weren't harmed. My 10 years of practice as a bedside registered nurse gave me the knowledge that helped them to understand the catastrophe that they may be walking into, the intuition that was needed to be able to say to them, something is going on with this patient, even if the monitors in the ICU didn't pick it up. I have saved many a life, not just because I'm trained to do so, but the intuition, working as part of a team, allowed me to be able to do it. APRNs are not asking to work independently. That is something that is bandied about a lot, and it's using our level of education as a way to scare people into thinking that we don't have what it takes to be able to do our jobs. But we do. There's 30 years of sound information and data that says that advanced practice nurses provide safe, quality care. The issue with narcotics here in Georgia or the opioid crisis is not an issue of APRN doing. At this point, We are not the ones that are prescribing opioids. It's physicians. And it is in our model. We don't practice medicine. I also want to correct that. We practice nursing. And it is part of our model to not prescribe narcotics or opioids if they are not needed. And so giving the smallest amount that will be able to get patients through an acute episode or through the weekend should be granted. As people, we want them to be able to have positive experiences. We want them to be able to have pain control. We want them to be able to have quality of life. I thank you so much for allowing me to address you this evening, and I'm willing to take any questions at this time. Thank you.
Thank you. We do have a question from Representative Earhart.
Actually, more of a comment. Thank you so much for your testimony. I learned quite a bit, and it's just really more just of a comment to a couple of things that you said as relates to the Schedule II narcotics. You know, we hear so much, and you've been done a brilliant job of communicating the need for this sort of thing. And for those of us, I can often say, bringing it home to a personal level. For any of us that have ever been in an urgent care with a child with a severely broken bone, for any of us who may have sat at the bedside of a parent who, in the later stages of a severe illness, to know that they are capable of having better access to the pain control that they need. I mean, for me, that just drives the point home. Also, on the issue of the home health care, I would think that with the ability of the APRNs to prescribe home health, I heard this a lot as I was walking through it with my in-laws. Given the choice of being at home rather than in a long-term care facility, but given the opportunity to remain in their home, for so many Georgians I know is just a very important thing to them in terms of their dignity, particularly as they're getting older. Anything that opens up and improves the ability, I think, for us to care for Georgians, to control their pain and to allow them to live with dignity is very important. And I appreciate for your explanation. You actually answered several questions that I had, so thank you so much.
I want to say thank you so much for your comments as well. Advanced practice nurses and nurses on a whole, 19 years in a row, we have been deemed the most trusted. And that is for a reason. It also goes to show that this is what the market says we are. This is what the patients and the communities say we are. We are the most trusted, not amongst our peers, but amongst them, particularly in the time of the pandemic, when we all have older family members that we would have been able to do anything to keep them home with us. People were in assisted care livings and home and nursing homes. Some of these people never saw their families again. If we had an opportunity to order home health care and keep people in their homes with families that love them, this would make all the difference and add years of life. 5 more years with grandma, what would you give for that? Mm-hmm. And so it's just, a simple ability for advanced practice nurses who are trained. We are qualified, we're educated, and I know because I educate them. And my students will tell you, I'm some of, at Georgia State and Clayton State, where Dr. Eichelberger are some of the toughest professors. And yes, we do not have as many training hours as a physician, but in order to be able to provide primary care, we have what we need, and the data says so. It's not me saying so, and it's not whatever the physicians will say. Numbers don't lie, and the data says that we provide safe, quality care. Thank you so much for listening. Are there any other questions or comments? And Chairman Jaspers, I also have an answer for you. You did ask how long protocols take. It's 30 days to 3 months sometimes when they have to be filed with the composite medical board. Just wanted to answer that for you.
Thank you very much for your excellent testimony. It's been very insightful and very helpful. Thank you very much.
You are most welcome.
Next, we have three other people signed up. Callie Michael. Callie, would you speak to us, please?
Yes, thank you, Mr. Chairman. I'll be brief. I'm Callie Michael with the Southern Group. I'm here on behalf of AARP. We are in support of House Bill 430 because it helps patients efficiently access health needs and reduces burdens on family caregivers simply by simplifying the patient access to basic health forms, improve access to home health care so individuals can remain at home and stay out of costly nursing homes. In addition, we support House Bill 369 for similar reasons. It alleviates burdens on family caregivers and can reduce hospital admissions when these prescriptions are necessary, but a physician is not available. It also allows APRNs to help fill the void in rural and underserved parts of the state where there are still physician shortages. So, if you have any questions.
Thank you, Callie. Any questions from the committee? Questions or comments? Thank you so much. Next, we have Bethany Shera.
Hi, thank you. My name is Bethany Scherer, and I'm here on behalf of the Medical Association of Georgia. MAG represents over 8,000 physicians across the state of Georgia. We rise today in opposition to HB 369 and HB 430. First, HB 369 removes the Georgia Composite Medical Board's review of nurse protocol agreements and job descriptions, and also takes away the ability of the board to set criteria for those agreements. So oftentimes when we're down here and we're sort of allowing for certain things to be delegated under a protocol agreement or within a job description, we also allow the Composite Medical Board to set separate criteria for those that might be related to chart review. It might be related to a lot of other things. So the board can set rules that are more stringent than the laws, and that's sort of a policy decision that was made along the way. So now by taking this back, it sort of repeals some of those things that we put in place along the way that, there may have been very specific reasons for doing that. It may be related to things like technology, that we knew technology was changing, and so it made more sense to defer to the medical board to set that criteria. The board's review of these agreements ensures that they comply with existing laws and rules, and by removing oversight, issues with non-compliance would not be discovered until a bad outcome occurs. This is especially important as we see expansions of APRN and PA scope, as there are in both this bill and HB 430. Removing this process is bad for patient safety. And I will say, I spoke with several members of the board who do these reviews, and they said that typically, if, like Dr. Newton was referring to, if a protocol agreement or a job description is very similar to something you've done before, they're typically administratively approved, and that can happen very quickly. So that can happen within, some small amount of time. Now, if there's something flagged within them and they can't administratively approve them, then they have to go through the different committees within the board to have further review, and that can take a month or longer, just depending on when the board is able to meet and review those protocol agreements. HB 369 also stands to permit APRNs and PAs acting under a protocol agreement or job description to prescribe Schedule II drugs. Schedule II drugs are defined as drugs with a high potential for abuse, with use potentially leading to severe psychological or physical dependence. These drugs are also considered dangerous. Included in this schedule is opioids, and Georgia and the rest of the U.S. are in the middle of an opioid epidemic, an epidemic only made worse by our current healthcare crisis. And Georgia has passed several pieces of legislation, including a prescription drug monitoring program, to reduce this abuse. A study published in the Journal of General Internal Medicine in 2020 found that primary care NPs and PAs prescribed opioids more often and at higher doses than did primary care MDs. Furthermore, 8% of NPs and 9.8% of PAs met at least one definition of opioid overprescribing, compared with 3.8% of MDs. There are other studies that have found sort of similar patterns, but this is the most recent study I have access to. And then as far as HB 430, this bill would allow APRNs and PAs to write the care plans for home health. We oppose this legislation because the patients who receive these services are some of the most complex patients with multiple medications, treatments, and services. The way HB 430 is drafted also gives me some pause, because typically when we're delegating these acts under a protocol agreement, we put that language within OCGA 433425 and OCGA 4334-102, and this is done in a separate code section. So it talks about the authority that it's a PA acting pursuant to that code section, but it then doesn't add it under those code sections that list out specifically what can be included in a job description or protocol agreement. And sort of when you combine this with what's happening in 369, that's concerning to me as I read it. So this could appear to grant independent authority to create these care plans without the supervision of a physician. And that creates a situation where there is no physician supervision of the plans for caring for our most complex patients who ostensibly need the expertise of a physician and also need that team-based healthcare that we talked about earlier. And these patients often need, sort of multiple different things. So Dr. Newton talked about the, numerous drugs that they might be on. They may be on other services, other types of treatments that sort of all combine into one. And that's sort of why we talk about needing that team-based healthcare, making sure that there are multiple people looking at these patients. And, our policy position would be that physicians are the best ones to oversee that process. And MAG does not believe that APRNs and PAs have training with knowledge or expertise on transitions of care to home health settings. Nurse practitioners must complete 2 to 3 years of graduate level education and 500 to 750, sometimes more, hours of clinical training. Physician and assistant programs are 2 years in length and require 2,000 hours of clinical care. If you compare this with a physician who will receive more than 10,000 clinical hours before completing their training. Team-based care with the physician as the leader of the team benefits all Georgia patients, and most especially patients with complex care needs. Happy to take any questions.
Well, thank you. Any questions or comments from the committee?
Yeah, I have one, Mr. Chairman.
Yes, sir.
Just real quick, ma'am. So I guess it's MAG's position that even 3 days is unacceptable for the prescription of opioids in an emergency situation.
I have not had a chance to take that language back to our physicians, but I'd be happy to do that this evening. I can only speak to the language that's in the bill, so just want to really protect. And Dr. Newton was right that in HB 249, which is the PDMP bill that we passed in, I think 2019, it set a sort of bare minimum. You don't need to check the PDMP if you're prescribing for 3 days or less, and the idea behind that is just that. Okay. The chance for abuse is low with that low of a prescription.
Okay. Thank you.
Thank you
Thank
very
you.
much for your testimony. We have one remaining presenter, Wendy Clifton, and there she is behind the column. I thought you had left us.
No, sir. Thank you, Mr. Chairman. I will be very brief because I know I'm standing between you and the door. On behalf of the Georgia Nurses Association, first I want to thank Chairman Powell for bringing the bill. And then I want to thank Chairman Newton, because I think some of the things that he said are very important about collaborative practice. What I've learned in my years of working for GNA is this, and in particular with the pandemic that we're all living through right now, and that is that we need more healthcare workers in Georgia. And if we don't expand the practice of some of the what are characterized as PAs or APRNs or whatever, we know we don't have enough doctors. We know we don't have enough nurses. We know we don't have enough PAs. And I think the two proposals that are in front of you today are asking us to consider, why are we so different from all the other states in the nation? Schedule II prescribing for APRNs and PAs have been done in 48 other states for many, many years. Some states like South Carolina are just moving in, but we're one of the few states left without having that authority. And I think the proposals in front of you are just, as you've discussed today, and I apologize, the mask. It is difficult, as you know, to breathe through it and speak. But it is important for us to have this debate and this discussion. So I just want to thank you for having this conversation and willingness to consider the proposals in front of you and know that Georgians are asking for this. The average citizen who goes to the doctor, even just a primary care doc, prefers to see their PA or APRN. Why? Because they take more time with them. They spend time actually talking to them and hearing what they have to say. It's no offense to the doctor, but even when I go, I just went the other day to see my doctor at Grady, and I spent way more time with my APRN than I did with the doctor herself. And that's just but the nature of what healthcare's turned into. So just want to say thank you. We support these measures. We support the increased conversations around providing better and more increased access to healthcare in rural Georgia in particular. These conversations take us to that place. Appreciate your support. Thank you.
Thank you. Any questions for Ms. Clifton? No comments? Okay, well, that concludes our witnesses. As Chairman Powell made it plain to us, this is a work in progress, these two bills, and so we will be in a working group format as we work on it to move them forward. So we appreciate your attendance today and appreciate the testimony from all of you, and we will stand adjourned.